Hello, I'm Neil Charness from Florida State University, and it's my pleasure to be moderating this very exciting panel. Our topic for today is barriers and opportunities related to the use of telehealth with older adults. And our sponsor is Eisai for this particular session. This is, of course, a GSA 2020 session. We have a wonderful set of panelists. Liz Hamburg, who's the president and CEO of Candoo Tech. Fred Kobylarz, who is an associate professor from Rutgers Robert Wood Johnson Medical School, and Barbara Resnick, who's professor at the University of Maryland School of Nursing. I thought I'd start out with a quick definition of telehealth. And I'm going to borrow it from a book that a group of us published a few years back. It's simply the remote provision of healthcare services and education by means of information and communications technology. Just a quick history. Ironically, if you look at the historians of telehealth, they point to the placement of physical signs at the entrances to villages to warn about the presence of plague in the Middle Ages. Ironic for today, because today you can get that information from just about anybody, anywhere over the internet. The real breakthroughs in telehealth came with wired telephone, which started to provide remote access to healthcare professionals when telephone networks, particularly in the United States, expanded during the 1930 to 1950 period. And if we look at more exotic forms of telehealth, remote monitoring, that actually started with the space program, when vital signs for astronauts who were being launched into space were monitored in the 1960s. However, what we're all dealing with today, of course, is COVID-19. And with COVID-19 came a quick appreciation of the risks that are increasing for both healthcare professionals and patients with face-to-face meetings. And the major impetus was, of course, Medicare, which, as you can see, started to provide widespread billing availability for telehealth services. That's taken from their website. With that, I'll stop sharing my screen and we can begin our panel session. Okay, so I'd like to start by asking our panelists in turn to share a little bit about who you are and particularly how telehealth has changed the way that you deliver care to residents, patients, and so on. So we'll start with Barbara Resnick. Barbara?
Yeah, hi. So from my clinical world, I do clinical work in a continuing care retirement community. So I have the opportunity to provide care to patients across the entire spectrum. Primary care and outpatient setting, as well as assisted living, as well as nursing home. And I would say that telehealth has afforded both many challenges and opportunity. I will talk about these more as we go through, but I really do feel like we're living with the challenges and opportunities.
Thanks so much, Barbara. Fred, can you comment a little bit from your perspective?
Sure, absolutely. Thank you, Neil. Hi, I'm a geriatrician, and I've been doing telehealth visits with community residing older adults and telehealth visits with nursing home residents during the COVID pandemic. Prior to the COVID pandemic, I was using telehealth from some geriatric consultations, but not like I'm using it today. At the start of the pandemic, I can say that 90% of all my visits were telehealth. Today, I've definitely increased the number of telehealth visits that I do, and I can say that a third to half of my visits are still telehealth visits.
Thank you, Fred. Liz, how about commenting from the perspective of someone who's trying to support telehealth services.
Absolutely. Thank you so much for the opportunity. So I'm Liz Hamburg. I'm the founder and CEO of Candoo Tech, and we are providing tech support and training specifically designed for older adults to help them stay safe, independent, and connected. So from our perspective, what we're seeing is we're getting the calls from anyone trying to get onto a telehealth visit or try to access medical records or connect their hearing aids. And we have a team of specially trained tech concierges that are doing everything remotely ourselves right now. So we've gone from in-person visits to all remote visits, and we're able to connect using a combination of phone calls and then using our special remote software. So we're actually getting into people's laptops and phones and tablets with their permission, of course, and while they're present, and helping them get onto these visits. So really excited to participate and hear both what's happening from the perspective of the medical community, and also happy to share what we're seeing as some of the barriers and some of the success stories. We've had some really wonderful success stories too, to get people onto those visits.
Thanks so much, Vern. Well, let me just open up for some general questions. I think today everybody, when they associate not necessarily telehealth, but video conferencing, which is a very important piece of it, although, as I pointed out, the old-fashioned telephone is our fallback method for an awful lot of cases. Can you say a little bit about, obviously we don't use Zoom, or maybe we do sometimes use Zoom for telehealth. Zoom certainly wasn't encrypted end-to-end to begin with, but I believe now they've started to change in that direction. They do have a protected version that's, I guess, HIPAA compliant. But what platforms are you all using, Barbara?
What platforms?
Yeah.
So because I do a variety of work, it is one of the challenges. It's a variety of platforms. And so because I work with many providers I'm in the state of Maryland, we have any number of healthcare providers and universities here. Everybody uses something different. So that's a challenge. Sometimes it is Zoom because that's what works easiest for people. And, we do have some protection around the whole issue of HIPAA given COVID. So I think that is another piece to think about. And sometimes, as everyone has alluded to, the fallback is quite honestly the phone. But it's a variety of systems. I can't even name them all.
Okay. Fred, how about from your end?
Yeah, no, I tend to agree with Barbara. I think that, well, in general, telehealth has really changed the way I, deliver care, and the different, settings where we see these, or where I see my older adult patients, lend themselves to, different platforms. I do want to just start out saying that nothing can replace an in-person patient-centered care visit with a physician, an advanced practice nurse, a physician assistant, or any member of the interdisciplinary healthcare team. For my outpatients, the platform we use at my institution is currently DoxyMe. This allows for audio video content with patients, and I can chat, I can send emails, I can get additional family members or caregivers on board. It allows for HIPAA compliant video visits. For my nursing home patients, the nursing home has set up a specific application, using Apple tablets. So in that setting, I've been using FaceTime.
Well, Liz, you have to provide support. That
Exactly.
must be a very interesting challenge.
Yep. So we are trying to really look at, where the trends are, and our tech concierges are trained to support, whatever the client needs. We are seeing, and I will mention too, that we're working with some physical therapists, with some social workers, geriatric care managers, to get them set up as well. And in that case, they are definitely using DoxyMe. In some cases, they have a compliant Zoom, and in some cases, frankly, between you and me, cheating a little bit and using FaceTime, which is not always HIPAA compliant. So, I think everyone's kind of moving in real time here. But I will say, and this is a really important thing that we're seeing, there's a lot of new technology and new hardware trying to come out and have, a fancy like standalone tablet or standalone systems to be able to provide those visits in the home or monitor remote patient monitoring. We are definitely seeing that our clients and their adult children or caregivers as well really do want to stick to using either a tablet or smartphone or laptop or computer that they currently have. So I would really encourage us as we think through what are the next trends and how to make things as simple as possible to really think about what software or apps we can put on top of existing hardware and not think about developing totally new hardware, because that just adds a whole level of complexity.
Thanks. And yes, I've certainly seen that in terms of studies that we've been doing in the community for years. People definitely want to stick to what they know already, particularly older adults. Okay, so let me ask a couple of questions about the advantages and disadvantages of using telehealth compared with laying on hands, as my geriatrician friend Paul Katz at FSU talks about as being kind of essential to good care, and having moved away from that model a little bit with visits to nursing homes, for instance. So Barbara, do you want to talk a little bit from your perspective of some of the advantages, some of the disadvantages that you've seen? Barbara, you're muted.
I would say one of the advantages is certainly access. For older adults themselves, I mean, sometimes it would even be a functional issue where they couldn't get into the office, or a concern about COVID exposure, that type of thing. So it's the access and safety and ease of a visit around a particular clinical problem. I want to reiterate, there ain't nothing like the real thing. And seeing a patient is so critical. That being said, some of the advantages that I have really found are, number one, coordinating, and I've done a good bit of this, coordinating telehealth visits with outside specialists. Traditionally, we send a consult note. Sometimes even a week can pass before you get anything back. You read this note and it's got all the wrong information on it. Well, now I can coordinate a visit and be right there with the specialist and the patient that I've referred, provide up-to-date correct information, and have a dialogue with the specialist that the patient really can't have at the same level. So it's an opportunity to really optimize those visits. Little problem here. They're billing, I can't bill. So fortunately, in my setting, I can do that, but I think everybody needs to recognize, as does Medicare, I believe, the amount of time that it takes setting up, coordinating, getting an older adult to and on these visits. God bless you, Liz, but all of us don't have a Liz. Some of us have to do it. And that really has a major impact. So that, and I want to say, not even for providers, but when we talk about the visits done in long-term care, the impact on the healthcare team in terms of setting these up, coordinating them, facilitating them is really, really major. And I think we need to think about that cost benefit.
Fred, would you agree?
Yes,
or do you see other things?
I agree. And, I think it gives me an opportunity to see my older adult patients in various settings. I think, a big advantage, as Barbara had mentioned, safety, physical distancing, we are reducing, exposures to infection, and probably also saving on, PPE. I think that when I see my older adult patient in the community, I see them in their home. You know, this is a whole snapshot of a setting that I'm just not used to seeing them in, and I just like have this whole different take on where they're coming from, and their home environment. Uh, I think, in the nursing home, I think, what Barbara was saying in terms of, I guess, just the ability to engage with the whole interdisciplinary team. And most important, I think, just, providing, access and this continuity of care, to our most, vulnerable, populations. I do want to say that, the tech support and the gods of technology aren't with you that day. It could be very, very time consuming. And then what I end up doing is I just pick up the telephone and it's just so much easier. But then the issue becomes, the billing piece, and then it's, not a face-to-face visit, but it happens, and, we just try to work through it as best as we can.
Speaking of the gods of technology, you're the goddess of technology for your company. Tell us a little bit about what sorts of problems you've had to troubleshoot.
Yeah, absolutely. Well,
particularly related to older individuals.
I have an amazing team. Well, we only work with older individuals, and I have an incredible team of what we call tech concierges, and they are really the gods and goddesses of this, and they've had amazing stories. When we moved to remote support only, frankly, we were quite concerned that not everyone would be able to get on. And I'll just share one story. We had an adult daughter call. Her father, Bill, was stuck in a senior living community, and it was early COVID. She couldn't get in to see him. He couldn't get out, and he had an iPhone, but had no idea how to use it. And he desperately needed to get photos to his doctor. And so our tech concierge was able to call Bill, use our remote software to actually get onto his iPhone, show him, guide him through how to take pictures. And he emailed the photos to his doctor. And at the end of the visit, Bill said to the tech concierge, "Today's my 105th birthday." So we love Bill, and we always say, if Bill can do it, anyone can do it. And he's our oldest so far that we know of, but he did have a successful visit. And, so we've heard these kind of wonderful stories where people are able to get on and to use technology. But I will just say, I think Barbara and Fred brought up a really important point. We're not talking so much about policy today, but I do just want to mention, you were talking about, reimbursement and who's paying for all this. So right now we're private pay, and but the way that we think about things is you can have the hardware and you can have access to the internet, Wi-Fi or broadband connection, and you can have the telehealth visit. But if you don't have someone there to actually connect the devices and show you how to use it and then be there to support it, we like to say sometimes it's a very expensive paperweight. And so, as you're thinking through policies and what Medicare has been wonderful at starting to reimburse both the visits as well as the hardware, but without thinking about, to your point, who's actually going to be there to set someone up and be there to support it, it's going to continue to be challenging. So I love that Barbara and Fred brought this up, and it's definitely an issue that we're looking closely at, and would love and welcome the community to continue to think about this.
Barbara, any reactions? Take yourself on mute. Yeah.
Yeah. So the I totally agree, Liz, and I'm thinking, unfortunately, it's often those that don't have the resources to access your services that are in need the most of help with technology and access. So we still do have major access issues. I did want to reiterate the value and the opportunity to engage the interdisciplinary team in a lot of activities, whether it's care plan meetings, where you can all be around the table, even people that might not be in the facility, because they used to be face-to-face. So I think that's really been a great thing to be able to do those, whether it's by telephone or some other platform. The other thing that we've done with an interdisciplinary group is annual wellness visits. And This has been really, really fun. It's actually with a student group, but this could be done in the real world. Again, because of reimbursement issues, it could be challenging. But doing a annual wellness visit where you really bring in different specialists, therapists, dental, we've had audiology that can interact with the patient. It's a great way for really to get a better comprehensive exam done, as well as really learn from each other and get that input from each other that we never seem to be able to do. Again, there's challenges because of payment.
Thanks. Fred, I want to raise another kind of challenge that has probably been evident to all of you. What about problems or issues like, for instance, language barriers, if you have a diverse population you're serving, or for instance, hearing loss, or how people use hearing aids with this, or we can talk about people who've got serious vision loss and the sorts of font sizes that they could tolerate, or screen sizes. We talked a little bit about an iPhone. There may not be that many 105-year-olds with good enough vision to be able to utilize an iPhone effectively if they've got one of the older, smaller screen versions. Any thoughts, Fred?
Yeah, no, I mean, this is communication, 101. This happens, with the in-person visit that, we really need to take in consideration because, hearing loss is very common and I think is often, very overlooked. And, my older adult patients don't like to wear their hearing aids. So, they'll be yesing me to death. I think vision, also we just don't, now we're having, them look into a computer or a little, tablet, so I think that presents, its challenges. But I, will say that, to overcome some of this, I am seeing and touching a little bit upon, what Liz had mentioned regarding, family and caregiver involvement. So I am seeing this change where I just, more families, the caregivers are getting involved, with the increased use of the video visits. So I think it does, help, get over, some of those, physiologic barriers. Now, the language issue, if your patient doesn't speak English, there are laws and, rules that we all have to follow. And, we do need to, if you don't speak, I speak, Spanish, I'm fluent in a couple of languages. So, when it comes to Spanish and my other language, I can communicate without an interpreter, but, we need to abide by, we need to conference in an interpreter, sometimes. And all this takes a lot of time. There's no reimbursement. And now you've got, this communication piece that's occurring with a family member, a home health aide, a patient, and we might have 2 or 3 different languages going on there. So it's, it's challenging, but, it needs to, we need to consider, these communication issues that are very, very common.
And
Speaking
Neil,
of
if I can,
communication, go ahead, Liz.
oh, sorry, I was just going to say that a lot of what we're seeing is, again, our tech concierges are trained, in fact, partially by your friend and colleague, Sarah Sajjang. Her team at Weill Cornell has been really helpful in helping us think through some of these issues. So for example, one of the first things we'll ask a new client is, do you have hearing aids? Can we connect them to your phone or your tablet? So we're connecting those hearing aids in advance. We're asking, do you have any vision issues? Do you have macular degeneration? We're then adjusting the screen background. So we'll start with a black background and white font. We'll increase the font size. So we're doing those things a lot preemptively, proactively. And there are some really interesting tricks we found. PowerPoint actually has kind of a cool feature. If you have a PowerPoint open and you can share a screen if you're on a Zoom, it will do automatic transcription, which is really neat. So if you're talking and you put that feature on, it will automatically transcribe. And of course, there's all sorts of simultaneous translation things. They're not perfect yet, but in some ways they may be better than doing an in-person visit if you don't have a translator. So there are things like that where technology can actually improve the visit. rather than be more difficult.
Let me follow up with another question, and it's something I guess I observed in the very early days when I started on research on telehealth. And of course, telehealth originated primarily in states like Alaska, where it was almost impossible to bring healthcare professionals in to remote villages and so on. But they were doing it with kind of dedicated television lines. Today, of course, we rely on the internet, we rely on Wi-Fi, we rely on connectivity through ISPs. We're beginning to rely a little bit more on basically cell providers. What sort of challenges are there for getting connectivity for patients that you've seen? And how do you go about circumventing the poor signal or lack of signal or those types of challenges?
So
Yeah,
I'm
Well,
just,
go ahead. Liz can go first, and then go ahead.
go ahead.
sorry, Barbara. Yeah, I was going to say we're seeing a range. So we're working with some area offices of aging around the country, where they are trying to bring tablets into people in very rural communities, low-income communities with no connectivity. And so in that case, what we're trying to do is we'll do a cellular data-enabled tablet. In some cases, we've had to do hotspots. So we've been purchasing hotspots and connecting tablets, which is not perfect because that also comes with its own set of challenges. But definitely not everyone has Wi-Fi, and there is still a huge digital divide. And that, again, this could be a whole nother topic that we can talk about. It's quite startling in this day and age that that's true, but that is the case. I will say one positive thing to come out of COVID, if I can think of one positive thing, is that especially with the remote learning going on, that more and more communities are absolutely, it's a necessity now to get kids connected. And so as the kids are getting connected, the older adults are as well in some cases.
Yeah, Barbara, take off mute.
Yeah, I was totally agree, Liz. And I just was saying I was laughing because my facility's in the city, and we just, it's like a lake where things are hot and cold, and you can be in some places in the building where you just can't get access. And the way it's, the biggest problem is so much of the use of these devices is self-efficacy based. So if you don't approach it with confidence, you almost fail before you start. And this is what happens to many older adults. It's discouraging, then people don't want to use it. So easy and good Wi-Fi access is so critical. And I agree also, Liz, we've done a lot within the city to help senior housing facilities get at least some access where they don't have Wi-Fi. And honestly, just, very, very few people have any type of computer or tablet.
Fred?
Yeah. And in New York City, they are putting a little bit of money. There's a new project going on to start wiring some underserved areas of New York City.
Fred, how about from your perspective?
I agree with Liz and Barbara. I mean, there's, dead zones. I'm in a big metropolitan area, and, we have these issues. And I think, access to, telehealth and, ethno-racial disparities and utilization of, these telehealth visits is a problem. And I think it just, as time, goes by, I think, things, will change, but, I think a lot of, research is needed in this area, and, it's a problem. When, like I said before, when I have an issue with the technology, I know I can get them on the telephone. So I just defer back to the telephone, and I do whatever, I can, whether it be, an acute visit, it could be just, a chronic disease type follow-up, or so on.
Thank you. Well, okay, so research is obviously a kind of a critical area that we want to see advance, particularly in this area of telehealth. Do any of you know about any, I guess, research that, first of all, demonstrates the benefit? I mean, today, of course, the benefit's obvious. It's access, or access would be impossible, perhaps otherwise. But are you familiar with research projects that have shown, for instance, the financial benefit for these types of telehealth programs? Do you know who may be funding research projects at this point, either federally or at the state level? And have any of you participated in research projects? Start maybe with Barbara.
So I just want to throw out there or remind everybody, if they are not aware, GSA has a COVID task force. And one of the things, we had a group within the task force that focused on identifying research areas. And telehealth is one of those areas, obviously. But I think the really important thing to think about is what really are the outcomes associated with telehealth, and what really is the benefit, and in what situations are there benefits. It's a great option to have. It's better than nothing, but are we really able to make differences? Do we really decrease hospitalizations, facilitate access to care? So I think there is a volume of research that needs doing. I don't think we have that at this time. It's going to take time to gather that data and really look at the outcomes.
Fred?
Yeah, no, I think this will become a new frontier to explore, essentially. I think some of the points that Barbara just made, I think healthcare quality and cost are definitely opportunities, to look at. For example, I'm familiar with, there is, data that's shown, reduction in emergency room visits, with patients using, telehealth. I think other areas that might, be looked at include, the clinical quality measures. I mean, we're all working, within an ACO, an accountable care organization. So I think looking at, clinical quality will, definitely, I think there'll definitely be federal opportunities to, submit grants in that area. I think not only access, but I think just utilization of, things like preventive measures. I mean, flu shots, depression screening, looking at, who the provider. I mean, is this telehealth visit, a physician that's doing it? Is it the advanced, nurse practitioner? Is it the physician assistant? I think, the whole issue of, detection of cognitive impairment. I mean, these will all be, I think areas that, will be opportunities. Again, what Barbara said, I don't think there's much that's happening, but I think, the COVID pandemic is definitely going to, spark, the interest, and, there will be opportunities to submit, pilot types of projects to, and who knows, maybe some of the healthcare systems will even fund this, because they're going to be looking at this data in their ACOs, and who's going back and forth to the hospital, who's going back and forth from the nursing home to the emergency room. So, I think, lots of, potential opportunities to look at here.
Yeah, it's interesting you mentioned the healthcare provider systems. I think the largest study I ever saw was the British study done by the medical system there. And that was, it was called the Whole System Demonstrator Project. And they looked at outcomes. This was probably the largest I've ever seen. Probably, I think it was a couple of thousand people enrolled in 2 arms of the study. And they showed some lower hospital admissions and lowered mortality. I think it was in a population of diabetes, COPD, and heart failure patients. But in terms of some of the measures that people at GSA might be interested in, like quality of life, they really didn't get anything there. And the sad point, this was done many years ago when the equipment was much more expensive than it is today. They demonstrated quite clearly it was not cost effective. So it did not make it on an economic analysis. But yeah, I would agree with everybody. Liz, I don't know, have you been involved in any research projects?
So we're starting to look at just keeping our own data on, particularly around social isolation. Is this technology, being more competent and confident with technology, is that helping to decrease social isolation, improve loneliness as people are connecting to friends and family? So less specifically around telehealth. But I definitely have seen some studies, and if anyone, I think it's UCLA, but it might be USC, and I know whoever is from one and it's the other is going to get offended. But so I can definitely check and send that over to anyone who's interested. But specifically around telehealth, and using telehealth and technology has been a great source of decreasing depression and social isolation. So we're looking at it from that perspective, but would really be interested if anyone does have that data, because
I'll
obviously
jump in
we're quite
and suggest that there's a group that Sarah Saj has been working with for quite a while called Create, and
Yeah.
they did a clinical trial on PRISM, looking at trying to alleviate social isolation and loneliness with kind of mixed results, but they got it at we got it at 6 months, and it kind of disappeared by a year. So yeah, there are research studies out aimed at those particular outcomes. But you're right, early in the process. Let me just end with we're getting close to running out of time, but I wanted to end with one other question, which is the challenges, which may be of real interest to people at GSA, the challenges of working with persons with dementia or other special populations with cognitive impairments and telehealth. Do any of you have any thoughts on that, or any advice to give in terms of setting up systems with those types of more impaired populations? I'll start with Barbara.
Yeah, so that's the majority of what I do work with, even in independent living, I hate to say. Okay. And I will tell you, it becomes a cognitive screening test. Can the person even do it? Particularly if it's somebody who used to use the computer, but now is no longer able to. It's a real sign. I am seeing, Liz, you'll appreciate this, more and more children who are connecting in to help mom and dad remotely do whatever. But it's a major challenge. And I have to say, unfortunately, it usually ends up in the person just not using the computer for any type of social interaction. And if they need to do a web visit, honestly, we're setting them up. I am not the queen of computer savviness, but I can get through, and I can set them up. And each time, believe me, I do it holding my breath. And Liz, I wish I had you on my shoulder all the time.
Anytime.
So it's a real challenge. I think along, we talked a little about vision and hearing. And I do think there's lots of things to augment. One of the nice things, if people are doing video, unless we're in the office together, they can take off their masks, and usually the specialist is alone, or whoever they're working with is alone. So I think that is one of the advantages, but it's really challenging. And often, when we're going back to the phone, it's literally their, princess phone at home. It's not even a cell phone for many people in my world. So it's still a challenge. There's not access to everybody, and dementia is a major barrier. I think somebody needs to develop a computer like we used to have for the kids that's got the one red button that you push and it makes it all happen. And you're good to go.
Well, and it's there. I know, Neil had mentioned the PRISM project. So that is something that there's a team involved with, and that's a really simplified tablet. And I know, Neil, the team is working on some issues and studies based on dementia patients. There are things like the GrandPad, which is a very simplified tablet. some pros and cons. I'm happy to, delve into that at another time. There's a tablet called IN2L, which is stands for It's Never Too Late, and kind of a very simplified. So there are these simplified interfaces. There's a phone called the Jitterbug. So there definitely are simplified interfaces, again, with pros and cons of each. And, but for people who need a lot of simplification, it's there. And, we've talked a lot about caregivers or someone who's in the home potentially with someone for that visit. And, we found that can help. And I think Barbara pointed out a really interesting point, which is that sometimes this is a first screening. We've trained our tech concierges to look out for any kind of cognitive decline or communication issues and challenges, so that we can then, again, with the right permission and confidentiality, be able to contact a caregiver or an adult child and just let them know that we've seen a shift.
Fred, any last thoughts
I
on that?
agree. I mean, I agree with Barbara and Liz. And I guess when I hear the word dementia, there's such a range. I mean, this could be, it could be, MCI, it could be, mild cognitive impairment, to, the more extreme. I mean, your advanced, dementia, patient that's literally, bedbound. And if you're doing the telehealth visit, the face-to-face, I mean, you can observe them, but, most of your information is, the informant, the family, the caregiver. They're really just, giving you, the information that you need to know. I actually think it's that early, so, we kind of hit the detection of cognitive impairment. That's, what we're supposed to, be doing in our Medicare annual wellness visits, and, just observation, and how much of this is just, not picked up, and whether or not, being able to navigate a smartphone or a tablet or a computer, kind of, gives you, a diagnosis of some sort of cognitive impairment. I think it's just, there's a lot there that, we just, need to take into consideration. And then even the testing, I can do a mini cog, I can actually do registration, recall, I can have them draw a clock, but then when I'm doing specific assessments, trying to use, for example, a MoCA, it's, we're experimenting with some of that stuff, but it's, I guess it really depends on where they are in that range of, disease. And, it's just a whole area that, that lends itself to, the clinical, the research, and even the education piece. I think, the associations, they're, the caregiver support groups have all gone virtual now. So it's really evolving.
Thanks. Well, I think our time is just about running out at this point. We're pretty close to finish. I want to thank all our panelists for what I thought was a very enlightening discussion of some of the challenges and the opportunities of telehealth. Any last minute quick thoughts, Barbara?
No, my only last thought on the last topic and the visual and the hearing, and it almost ties in as well to the cost piece, is when there are those challenges, add on another hour to these visits. So again, it's important to remember that what we can do via telehealth takes a lot longer than it does with a face-to-face visit, where I can maybe facilitate the communication. And then if you're like working with a caregiver who's translating everything to mom or dad, it goes on forever.
Fred, last
Yeah,
minute.
no, I agree with what Barbara is saying about the in-person visit, and it's the future. I think the COVID pandemic has definitely accelerated, changes in healthcare, and we're all adapting, both, as healthcare professionals, along with our patients and their families, and caregivers. I think it, meets the challenges of, the pandemic, in terms of safety, exposure to infection, those kind of things. But we just have to start getting used to it. It's something that's here, and it's a new change.
Last thoughts, Liz?
Well, I loved your example of the astronauts being some of the first telehealth visits, and I have that image in my mind, and I think we've definitely come quite far, but we still have a long way to go. And so I've been seeing some really interesting things with using robotics to do telehealth visits and be able for like an ear, nose, and throat doctor to be able to literally look in someone's ear from 200 miles away. And so I think we're really at the precipice of something very, very interesting, but it certainly is not easy. And I think that COVID has just made us accelerate all the things that have been talked about for a long time. And so I completely agree that this is here to stay, and we're going to see some real innovation coming out of this.
Okay, so I think a recent editorial in one of the telehealth journals says, our day has finally come. And on that, I'll wrap up this part of the panel, and we will shortly open it up for questions. Thank you so much for listening.
Thank you.
Thanks, everybody, for listening. And now we're going to move into the live question and answer session, what you've been waiting for. So we have quite a large set of questions here. I'm going to pick them, not quite at random, but let me direct the first question to Fred. Fred, the question was, let's see here, can you comment on the special issues and considerations associated with a telehealth visit for people with cognitive impairment and their family caregivers?
Yeah, so I think that that's a great question. I think it all ties into key geriatric care principles, and just observing. You can do cognitive assessments. You can do something like the mini cog, the registration recall, and have them actually draw a clock and take a look at it on the video. You can ask the informant, you can ask them some specific, questions.
Does anybody else want to comment on that question as well? If so, please unmute. Okay, well, let me move on to another question, and one I think that's I'm going to give to Liz. Liz, can you discuss the issues around Medicare reimbursement, particularly for the sorts of coordination of care, time spent coaching clients and tech, delays with tech, and then if there's time, can you also, and maybe I'll ask this of all the panelists, can you speak to current expectations for whether HHS is going to permanently allow telehealth for all Medicare beneficiaries, not just those in rural areas that was allowed pre-pandemic? So a multi-part question, there's an additional piece, but let me turn it over to you, Liz, to if you can unmute and respond.
Absolutely. Hi, I am unmuting, which also means you may hear my lawnmower going. So please excuse some noise here. But yeah, the short answer is no. Medicare and Medicare Advantage plans are not currently reimbursing for the tech support and training that so many older adults in particular need to be able to access telemedicine. So it's a great question. And I would love to actually get feedback from the audience on what we can all do collectively to spread the word that this is an absolutely critical need and a critical part of making sure that these visits are successful. And I can just tell you, as a side note, that when we're talking about equity and access to telemedicine visits, it's something that we think about a lot. We are actually working with several social service agencies, area offices of aging, and nonprofit groups around the country. So they're not getting reimbursed by Medicare or Medicare Advantage, but they are getting some CARES Act funding as well as some private grants to be able to purchase tablets and to bundle those services in to make sure that, in particular, that low-income clients and patients are able to access the technology and even more importantly, understand how to use them so they can get onto those visits.
Thanks. Anybody have any further feedback and particularly speculation on whether or not you think HHS might carry this policy forward?
So my feeling about it is it's really going to depend on demonstrating benefit. And we really do need to continue to look at what is the impact of a telehealth visit. I mean, qualitatively hear a lot of mixed things from patients and caregivers that are participating in these. And I think that's what's going to make the difference. Do they, in fact, help decrease hospitalizations? Do they help to decrease people getting inappropriate testing? Things like that. So a lot more remains to be seen.
Thank you. Let me hit another question. I'm going to direct it to Fred first. How do you do, and it's related to one I think you've started to address, how do you do patient assessment on telehealth, particularly regarding function and the home environment? Fred, you have to unmute. Fred, unmute. There we go.
Great. I think that's a great question, Neil. And again, like I said, this really ties into key geriatric principles of care. It's all about really being a good observant or detective. For example, gait. It might be, challenging to do a get up and go test, at home, but you can observe, certain aspects of this. You can see what assistive devices they have at home because, sometimes they just don't come into the clinic, setting with them. Regarding upper extremities, you can have them go through some maneuvers and do some functional assessment. This ties into the, activities of daily living. If there's a caregiver present, during the, the actual visit, you can also use them as an informant.
Others want to add to that?
No, the only thing I would throw in is to remember the use of the interdisciplinary team, particularly if you're doing an eval in a nursing home or assisted living, where you really could direct somebody to do higher level, whether it was range of motion or even evaluating pain, to really walk somebody through, push here, move this, can make a big difference. At the same time, I'm just going to throw in there, being respectful of other disciplines and their time, and making sure that we do good coordination of these visits.
Right, and Neil, I just want to tie in, the home environment, is just so key here because, it's part of the social history and you're getting a lens into, where they're actually living. And you don't really, have any sense of this when they come into the clinic. So, you really, get a sense of what the home environment is like. It's almost like doing a home visit.
Yeah, that's a really good point, and I think one of the advantages of seeing your patients in context that you may not get otherwise. Let me. There's some questions that are related to that, and let me just ask about. This was. Can anyone on the panel speak to the pros and cons of telehealth for group visits in older adults? They're thinking of things like mental health or rehabilitation services. Has anybody heard about or had experience with a group telehealth session?
We've been doing group. Oh, sorry, Barbara. Just to say, we've been doing group lessons and had really quite a lot of success with getting people onto video chat platforms like this, like Zoom or other things, where they are able to participate and interact. So we've had some really strong success, not so much with telehealth visits, but with their ability to learn things and also just to form groups. So we've had some really wonderful experiences where we've been able to really see that it's decreased social isolation by creating communities of people where they can share even remotely.
So similarly, we have seen use of groups with regard to exercise interventions in research or clinical work. So you could conceptually see, for example, therapies doing group-based therapeutic interventions and be able to bill for those via telehealth service.
Yeah, we've also been
And
doing, oops, sorry.
Oh, go ahead, Fred.
No, I was just going to say, caregiver support groups and education for patients that, have, dementia. And, this has been a tough time for a lot of those patients because things have, your adult care, daycares are all shut down. They just are, so our social workers have been, working on some of this.
And I was just going to add that we are working with several senior centers that have now had to go remote, of course, unfortunately. And in particular, one I'm thinking of in the Bronx in New York, where they have a chronic pain management program, and they've had to move everyone into a virtual setting. And so we've been doing both one-on-one and group lessons to get them comfortable again with their technology so that they can get onto those chronic pain management sessions and access other senior center resources remotely.
That's great. Thanks, panelists. Another kind of related question to an earlier one, and I'm not sure who would like this one, so I'll just give you the question. On equity and access, how may telehealth be pushed to multi-unit affordable housing as a shared amenity? And what are some of the challenges on that? If anybody is prepared to try to address that.
Yeah, and again, I think I touched on that a little bit when I was talking about some of the work we're doing with low-income seniors. We're working with several projects in New York City in particular, where social service agencies, nonprofit groups have senior residences where they have gotten funding to put Wi-Fi into the buildings or provide Wi-Fi data-enabled, cellular-enabled tablets, where we are then able to, to train them up and teach them how to use it and be there to support it so that they can access those visits.
It's challenging, I think, Neil. They still prefer the telephone, and unless they have the technology, the tablets, the internet service, it's very, very challenging.
Yeah, well, telephone is a wonderful tool still, and maybe underutilized a little bit, given all the bells and whistles we have now available to us. Let me address the next question to start with to Barbara. How do you access persons with dementia who live in long-term care settings, especially if they are stressed and short-staffed? In other words, there's often a cost associated with implementing these as new services.
Yeah, and this is to my earlier point that it really is quite burdensome for staff coordinating these telehealth visits. So being respectful and coordinating to make sure it's a good time, having somebody there, because these things do take time. Between technology glitches, and Liz, we'd all love to have you on our shoulder. And particularly many of the staff don't have expertise, but it's really getting that coordination. And then just like everything else, when we make a visit with a resident, you really do have to think about timing depending on what you want to do and what you want to see. So they're not, they're wonderful in many ways, but they're not simple.
Fred, go ahead.
Yeah, and if I, just add to that, that it could be a, simple, type of telehealth visit, But if you're going to start, trying to incorporate any kind of peripheral medical equipment, such as like digital stethoscopes and other similar type of equipment, it could be very, very time consuming and challenging for the staff.
All right. Well, if we're getting close to wrap up, let me squeeze in one quick question, which might have a short answer. I do telehealth annual wellness visits from home. How do you bring specialists into a telehealth visit? Anybody want to jump in on that one quickly?
Just coordinate the call. We do that a lot. It, again, like everything else, may take a little time, but it's just coordinating. We do an interdisciplinary group of individuals to do telehealth visits. I mean, annual wellness telehealth visits.
Okay, great. All right, well, I think our time is just about up. I want to thank all our panelists for a wonderful, wonderful set of presentations and discussion. I want to thank all of you who've been asking some really great questions to our panelists, and hope you enjoy the rest of your time with us here at GSA. Again, thank our sponsor, Eisai, for having put this one together, and others who've also been involved. Thanks. Bye-bye.
Thank you.